Hello and welcome to Dr. Doc's Performance Playlist. I'm your host, Carly Doherty, Doctor of Physical Therapy, Certified Strength Coach, and Sports Nutrition Coach. Today I want to talk about one of the most common injuries in sports, the lateral ankle sprain. Even though ankle sprains are so common, only about 50% of those individuals go seek treatment. Today I'm joined by Shaun Reghabi, Doctor of Physical Therapy and Athletic Trainer. Shaun and I both went through an orthopedic residency and obtained our OCS. So the evidence I provide in this podcast all comes from the clinical practice guidelines for treatment of the lateral ankle sprain. I want to get Shaun's expertise in real time on both acute ankle sprains, chronic instability of the ankle, and how athletic trainers and physical therapists can work together to get the athlete back to their sport as quickly and as safely as possible. So, Shaun, thanks for joining us, and go ahead and tell us about your background.
Hey, Carly. I'm super pumped to be here. I've spent my entire career in the sports rehab, human performance realm, working from 6A high schools here in Texas all the way to high level professional human performance companies. So I've definitely had a lot of experience with athletes and definitely a ton of ankles.
What are the biggest differences between the athletic trainer and the physical therapist, and what are some similarities that you see?
Yeah, so I think when you take a look at ATs and PTs, they're two sides of the same coin, but they also have a lot of differing factors too. One of the first things that when I think about an AT and being an AT is we're usually the first one on the scene. So we do the acute evals, we help rule out any red flags. We take on-field care super seriously, and obviously the classic, we protect, brace, and tape. And then we also help with those real-time return to a sport or game decisions. And in terms of that too, it's a big thing to be on the sideline with athletes. On the flip side, with PTs drive a lot of that progressive clinic planning. So loading, dosing, manual therapy, motor control, testing, and clearance criteria, whether that be post-op or something acute. But there can be still a lot of overlap between the two professions, because not saying that ATs can't do those things and not saying that PTs can't also do some of the more acute stuff, as you see with some of these specialty certifications.
Yeah, I got to work with Shaun during one of our half marathons, and definitely seeing what he does in real time right when somebody gets injured is a little bit different than what I'm used to when I get an athlete after the injury a few days or a few weeks afterwards. It's definitely different from the what to do right in that moment when the athlete gets injured right away versus treating a few weeks after the injury. I got to learn a lot from Shaun in that case.
It's definitely good times working together in that more acute setting versus being in the clinic. But that also shows the widespread of what PTs can do and vice versa. When I was an AT before going to PT school, being in the clinic as well.
Shaun, most basketball players that I work with have had recurring ankle sprains. Ankle sprains are most prevalent in high school female athletes who participate in court sports, so basketball and volleyball are very common. A lot of times when athletes sprain their ankle, they continue playing and don't rehab properly. Research actually shows that 40% of athletes who have a lateral ankle sprain will develop chronic ankle instability, which is likely due to the fact that they don't seek PT after their injury. Risk factors of acute lateral ankle sprain includes being female, hip abductor and extensor weakness, poor performance on balance and hop tests, and participation in that court sport. The risk factors for ankle instability, which is just pain that lasts longer than a year from one or more lateral ankle sprains. This includes not bracing, not participating in balance and functional performance program after that initial ankle sprain, and a higher BMI. So, Shaun, let's say a basketball player sprains their ankle midway through their basketball season, and the doctor says that the athlete must rest for 3 weeks. How can the athletic trainer and PT collaborate in season rehab to ensure that the athlete gets back as safe and as quickly as possible?
Yeah, that's a good question. Tons of physicians, you get the classic out for 2 weeks, out for 3 weeks. And resting doesn't necessarily mean that the athlete does absolutely nothing. Resting means we need to take care of the more acute processes that happen with the body after an injury. But resting can also allow us to do other things like more optimal loading at the right times, because it's all about timing, tissue healing timeline. We talked about that in residency a lot. I think if we take it in a step-by-step approach, so AT can be very beneficial in terms of getting the swelling down, compression sleeves, maybe some wraps, helping with some post-acute swelling with elevation, and then helping with some light loading with weight bearing is tolerating with some micro drills. And then PT comes in, can help progress a little bit more early loading, working on range of motion, isometrics for the peroneals and calf if like those didn't get strained. And then working on other things like hip glute activation and some other gentle manual therapy interventions. It's a team effort. So they both helping decide when to progress or regress depending upon what's being seen. And as you continue going through that the next couple of weeks, then progressing more of that strength and balance as everything's healing on up, you can start integrating some more guarded practice exposure. Because again, the AT sees the athlete a lot more than the PT, but they're still in collaboration together. And then progressing through the rest of the weeks, just continuing as we get that return to play classic plyometrics on the PT side, change directions, a little bit more nuance, looking at the actual movement mechanics. And then AT is going to be working more on the court decision-making skills and reactive drills. Because again, it depends on where you're at with your program, if you're actually at high school or not, but with that AT seeing a lot more. But again, everything is shared going through the entire process.
Yeah, I like what you said that the athletic trainer oftentimes sees a lot more of the athlete than the physical therapist does. A lot of times after an ankle sprain, I'll see somebody one time a week, if that. So it's super important that the athlete goes to their athletic trainer every single day. A lot of times coaches are pretty good that if an athlete's injured, they'll send the athlete to the training room while they're at practice. So it's huge to have that cooperation and collaboration between the coach, the athlete, and the athletic trainer and PT as well. So thank you, Shaun. There is level A evidence to use prophylactic bracing and or taping to prevent first-time ankle sprain for those in the court sport with the risk factors that I mentioned earlier. So the evidence shows that specific shoes like high tops or orthotics does not seem to help prevent ankle sprains. What is your opinion on ankle bracing versus tape? And should the athlete in court sports wear them on both ankles when only one is injured?
This is always a great question. And I always think back to a classic PT school saying of it depends. But when you take a look at both, they both reduce that risk of spraining or re-injuring again. Braces are nice from the fact that it provides the consistent support for the full session that you're in. And then also long term, they're also super easy to apply. So if they start getting loose, you can just retighten them back down. And then over the span of an entire season, it's super cost effective. Tape is also really great too. And I know some athletes prefer one versus the other. They really help with great proprioceptive feedback versus a little bit more bulkier ankle brace. But that kind of support compared to a brace drops over time within either the practice session or even a game, just because, you're moving around, you're sweating, that's starting to wear that down. So it needs to be reapplied again by a skilled clinician that knows how to do that. In terms of bilateral support, it really depends on previous injuries. Have you injured both of them? They both help reduce the re-injury risk. I always caution athletes for using both. We still need to make sure that we're ensuring the strengthening and proprioceptive feedback because sometimes muscles get a little bit lazy. Our body's very good at compensating. So if you start relying on braces or taping too much without doing the legwork, then you start using that as your crutch.
Do you have any opinion on the basketball shoe? I know the research shows that there isn't really much of a difference between the high tops versus not, but what have you heard in the athletic training world is if a shoe matters?
I think it goes down to, athlete comfort. Some people try to get into the latest, greatest shoe. It was the same thing. Even when I was playing soccer at college, everyone wanted to have like the lightest shoe versus a heavier shoe. I think it comes down to the athlete and what's most comfortable and supportive.
After an ankle sprain, there is A-level evidence for early weight bearing and to use bracing, taping, or crutches if needed to make sure that their walking mechanics is getting better. Early mobilization has been seen to be superior compared to immobilization, such as walking in a boot in most lateral ankle sprains. So this, of course, depends on the severity of the injury. However, even in the most severe lateral ankle sprains, it is suggested to only wear a boot for up to 10 days maximum post-injury. Shaun, can you explain the rehab myths, so Rice and toughing it out, and how this affects their rehab process, and why or why not to wear a boot?
Yeah. So when we take a look at some of the more classic methods of Rice, rest, ice, compression, elevation, literature shows that it's a little bit more outdated. There's more updated versions, price, meat. I think for me, ice could definitely help for like that first acute onset of 24 to 48 hours to help with that pain. maybe a little bit of swelling too, but in reality, it's about the movement and load while you're adhering to the tissue healing timelines. That classic way of toughing it out. Yeah, that's a quick way to really get that chronic ankle instability and then have that repeat sprains. So painful limping and trying to have that mental toughness that gets you at a higher risk. In terms of the boot versus no boot, it kind of depends. Like you said, for the higher grade sprains, you can have that short boot spell that provides some immobility while you're healing up through that tissue healing timeline. You want to still move. So I think functional bracing, or like if you use the boot, you still are adhering to some of the exercises your AT or PT is giving you to still help with that movement and loading, just so that way we don't have that prolonged immobilization, secondary effects of like weakness and stiffness kind of getting on out.
You mentioned improving pain levels. What are your thoughts on using a TENS unit? Or a lot of times I'll get a script from a doctor that says to use ultrasound for an ankle sprain. What are your thoughts on those two treatment methods?
This goes back to my AT background. I'm never opposed to those types of modalities. Now, I don't use it as much being PT in the clinic. TENS definitely will help with the pain. Ultrasound, if you take a look at some of the literature, it has some weak evidence for ligament healing. I don't allow the more passive modalities or interventions to replace the progressive loading and movement adhering to the healing timelines.
When looking at the evidence too, it shows that ultrasound can actually increase the swelling because it's providing slight heat. And so if you're having all of the swelling in the ankle joint, adding that ultrasound can actually worsen the swelling. Research also shows that manual therapy in conjunction with the exercises has been seen to do better. So when you're going to the PT or athletic trainer, if they're actually trying to push that swelling out of the joint, that shows to be better than ultrasound. So, Shaun, how can we bridge the gap between being cleared and actually being game ready? And what should student athletes know as far as education, return to play, and mentally when returning from an injury?
I think if you take a look at bridging the gap from a clinician side, it's the communication between the AT and PT physicians. But for what athletes should know is you should progress your recovery in an objective manner. We got to look at the data. A lot of the data from research shows we need to bring down the pain and the swelling. Then we progress through some of that like loading that we talked about. Range of motion wise, we look for certain things like the dorsiflexion lunge test, so the knee to the wall, looking for a certain number of being within 2 to 3 centimeters of the other side. Strength testing, a lot of literature shows being able to do those heel raises or those calf raises at least 25 plus times. It's full height, pain free. Then you also have to take a look at balance control. If anyone's ever done the light balance test, we're looking for a limb symmetry index of greater than 94% is what the research is showing, particularly in the anterior reach or the forward motion. Then also agility, hop testing, again, looking between 90 and 95% within the non-affected side. Also, you can't negate the practice side of things because, when we're in the clinic or in the training room, we're in a bubble. And so you're able to do all these things and that's great. You hit these objective measures, but how does that ramp up into your practice and play too?
Yes, so once the athlete can pass all of my tests, I still don't completely clear them because I make sure that they can do a whole week of practice without pain. Because very happy that they can do the single leg heel raise with no pain. They can do all of our jumping and lateral cutting, but all of that is with no contact. So I need to make sure that they're safe to play whenever they go 100% at practice. They're running full speed, jumping full speed. And then if they have no pain, then I'm like, all right, let's get you back to playing. So that's the biggest thing of making sure they're mentally ready as well.
Yeah, and that comes with having the confidence as well, because you can hit all these objective measures in clinic or in the training room, or even have that mental toughness and confidence to go back in. But sometimes when you're actually having to react to other players or other situations, being ready to be able to do that gives you the biggest chance of success.
Exactly. So, Shaun, since you are both an athletic trainer and a physical therapist, what makes a successful relationship between the AT and the PT? And how do you see the overall communication between parents, coaches, trainers, and athletes?
One of the biggest things to have a successful return is the communications. It's having one plan, one language, and having shared criteria over this return to play or this recovery. When I was in the high school setting here in Texas, I would constantly communicate with the PTs. And again, they were my friends, but like we would still communicate. And even those that I didn't know at the clinic that they were coming from, I would always let the athlete know. I would give them my card to give to the PT, and sometimes we'd have phone calls, sometimes we'd have emails. Shoot, sometimes I would just give myself, like, text me because it's the fastest way to get a hold of me. More the athlete side, parents and coaching, is just having the transparent education, not keeping them in the dark. I always tend to maybe overteach in some of my settings of talking with parents and athletes, but it's because if I was in their shoes, being a former athlete, I would want to know what's going on. But then now too, even being a parent myself, I like to be kept in the loop to kind of see what's going on. I think that helps out a lot. Also, knowing if something doesn't feel or smell right, it's knowing that time to escalate it back to the physician. If you feel their recovery isn't going the way that it should be, or maybe we're not hitting timelines or something else is going on, maybe there is something more than just the ankle sprain. So it's also having the communication with the physician as well when it's starting to kind of get out of our scope and see what we need to do from there.
So, parents, the coaches, the doctor, the athletic trainer, just to make sure we're all on the same page, and it goes a long way. They like to know that we're looking out for their athlete, making sure that we're putting all of the effort that we can to make that communication happen. Everybody wants to know that they're in the loop and what the best treatment method is for their kid. Hey, Shaun, you being an athletic trainer, what are some stories that you have or that you've seen as far as lateral ankle sprains go?
Yeah, I've kind of seen the gambit being on kind of both sides as a dual licensed clinician. I've kind of seen everything from your classic first time ankle sprains and first injury ever for some of the younger athletes, all the way till athletes dislocating their ankles, which is obviously never a good thing. Touching back to what we were saying earlier is even though it may just be an ankle sprain, to let the athlete know maybe it's a small injury or maybe it's a more severe ankle sprain, you're still an athlete. You're just in a little recovery phase from there and just going through the process. Trust the process as you're going through it.
Yes, even though it seems like just a mild lateral ankle sprain, if you don't correct muscle imbalances and poor balance, then you go and play, and then something severe might happen, like a knee injury or hip injury, because the ankle helps with your jumping, your landing mechanics. So if those are impaired, something up the chain might also get injured. Thank you, Shaun, so much for your expertise. Do you have any last minute advice for athletic trainers, physical therapists, or just the athlete?
Anytime, Carly. I think the biggest takeaway is the communication part from an ATPT side, but also from the athlete's perspective is just learning a little bit more as you're going through your rehab process. I think this is awesome what you're doing and done with this podcast as well. Strong ankle, stronger season. So that's how we do it.
I look forward to talking to you more about the athletic trainer and PT collaboration, and definitely going to ask you more about other injuries as well. But these are the takes on the lateral ankle sprain, and I will provide some other research in case anybody else wants to read more on this topic. Thank you so much and have a great day.
Thank you.